All right. Good afternoon, everyone. Welcome to today's session. My name is Catherine Freeland, and I'll be moderating the session titled Integrating Hepatitis B into State and Local Viral Hepatitis Elimination Planning. This session will highlight the importance and impact of state viral hepatitis plans at various stages of development. We all know how important it is to get our policymakers and state officials on board with our efforts to eliminate hepatitis B and viral hepatitis more broadly. This session will describe different strategies to create elimination plans as they're in different phases of development. I just want to remind everyone that you will be muted during today's session. We will invite you to ask questions out loud. But as the panelists are speaking, please be sure to mute yourself so we don't get feedback. So we're going to start today's presentation with our speaker from Hawaii, and this will be followed by our speaker from Pennsylvania and New York, who will highlight their elimination planning. And we'll also hear from a national perspective from NASTAD, which will share really what's going on at the broader national level in terms of elimination plans. So at this time, I'd like to start by introducing our first speaker, Thaddeus. He's currently the Viral Hepatitis Prevention Coordinator for the Hawaii State Department of Health and Harm Reduction Services Branch. He's also the co-founder and co-director of Hep Free Hawaii Coalition, a community-based program focused on increasing awareness and access to hepatitis services in Hawaii. In 2018, he was recognized by the National Minority Quality Forum as 40 under 40 leader in minority health. He is currently a Bloomberg Fellow at Johns Hopkins School of Public Health. He approaches public health from a social justice perspective and seeks to leverage community partnerships and system-level policy changes to address health disparities regardless of disease state. At this time, I'd like to welcome Thaddeus.
Awesome, thank you so much. And aloha everyone. Really appreciate this opportunity to share what we've done in our little island state. So I think I believe that you folks have the slides, so you're gonna share for that. But just for those of you who don't know me, like Catherine said, I'm Thaddeus, he, him. I'm the hepatitis coordinator for the Department of Health in Hawaii. I'm also the co-director for Hep Free Hawaii. I always make this joke, but it's kind of true that I've been called many things in my life, and hepatitis coordinator is one of them, but locally, a lot of people call me the Queen of Hepatitis. So I still respond to Your Highness, Your Majesty, or any other royalty epithets. Okay, so what we'll talk about today is Hep Free 2030, you can see right behind me, which is the Hawaii Hepatitis Elimination Strategy. So we start with this in a way because this is basically showing you what we did and how we did it. And this is very pulling from the document that we created. So we start and we open the document and also our presentations with the acknowledgement that this is dedicated towards people living and affected by hepatitis and the people not only who've passed from it, but honoring the people who continue to do the work and to showcase their resiliency. So really just to kind of have that empowerment and strength built into our elimination strategy. You could see here the proverb, it's in Native Hawaiian, so I'm not going to attempt to restate it, but what it means is, though the sea be deep and rough, the coral rock remains standing. And I think as we crawl to the end of 2020, this idea of steadfastness is very important for our communities and for us in Hawaii particularly. Next slide, please. So I'm going to skip this one. Next slide. I think we can all, if you'd like, I would just encourage you just to put your name, your organization, and your pronouns in the chat, just so we can get to know who's on this with us. This is the proclamation from Hawaii, so you can skip that. So next slide. And this is just showing that our work is community driven, but we recognize the importance of having policy leaders and governmental leaders as part of the process. So we were very intentional in leveraging, I would say, our relationships with local policymakers and national policymakers as well. So Lieutenant Governor Josh Green supported the strategy. Next slide. I think many of you will recognize Senator Mazie Hirono. She's super amazing. She supported this. Next slide. Senator Brian Schatz. And then next slide, please. So what is happening in Hawaii? I'll acknowledge that we don't have surveillance data really. So, but for those of you who are working in health departments or in community-based entities, I don't think that should limit you. I bring this up also many times, but one of my mentors told me, don't get mad, get data. And with 2020, we can get mad and get data, so it's not mutually exclusive. But just to know that there are data opportunities out there that are not necessarily surveillance. So what's happening? We pulled this together, and you can already see our strategy is very visual, very accessible, hopefully, and very engaging. So we turned this, rather than a data table, into data little infographics. So what are the main messages? We know liver cancer in Hawaii is high, and we know the leading causes in Hawaii are viral hepatitis B and C. Next slide, please. Looking at other data sources, we start to pull out and acknowledge and name the communities that are impacted by hepatitis. So we know it affects houseless people. We know hepatitis affects sexual gender minorities, or LGBTQIA+. And we of course know that it affects Asian Pacific Islanders, especially those who are foreign born. Although the community is not as big in Hawaii around people from Africa, of course, that is an important community as well nationally and in other jurisdictions. Next slide, please. And you can see here Hep C affects many people as well, and we name them here. Next slide. We also acknowledge, and I love that the storytelling piece was that first day of the summit, that stories are data, and they're very powerful data, and sometimes even more powerful than the data tables that we like to kind of put together. So as part of our data component, we highlight local people and local stories. And some of you might recognize Kenson and Rensley right there, who participated in the Just Be activities and created their own stories. We have Miss Page over there. Next slide, please. And we have Jade, Peter, Stacia, and Eddie. So just really acknowledging that it's the reason we're doing this work is because of local people and their local stories, and to contextualize data in lived experience. Next slide, please. So this is a slide that's very important. And you might notice, I'm going through a lot of these community pieces because it was so essential to our process and into our final strategy. But we, working with communities over a year, we had over 20, I think 26 separate formal meetings, not including informal meetings, texts, people sitting at syringe exchanges, people just doing individual Zooms with me to get feedback with over 120 different stakeholders. And so we listened to them, and what they said is, we want you to name the communities that you will be serving to show that they are important. So these are just this is a whole page in our strategy, because we really wanted to acknowledge that these are the communities we serve, and to further justify our work around social justice as a part of our work around hepatitis. Next slide, please. So it's a little bit of our history. I'm going to actually read this to you now. Just kidding. I would never do that to you. Next slide. Let's look at a visual thing. Timeline, right? So again, this is intended to be very visual, very engaging. So these are just colorful highlights of our past 10 years. Our coalition will actually be 10 years old next year. Another reason to look forward to 2021. So very excited. Next slide. I think you're going to see the other part of the timeline. There you go. And next slide. I'll add at the end of that slide, you'll notice that we started our planning process July 28th, World Hepatitis Day in 2019, and that we finished it a year later in July 28th, 2020. So a large part of our planning process was done during COVID. And so just to acknowledge that despite all the different challenges we've had, I think very inspiring to hear the presentation right before this with all the community members, that we can still provide service and engagement with our community despite the COVID pandemic. This is our mission, vision, and values. We started every single meeting by restating our mission, vision, and values. And we really embrace the idea of a values-based strategy. So we still use data to action as a big piece of it, but we really use the values as our lodestar, so that if we ever kind of go off our values, we know that we need to come back, but also to justify our work again in the broader context around social justice. So I'll just restate our values really quickly. You see the first one is harm reduction. So that's patient-centered, that's non-judgmental. Next slide, please. The next value is social justice. So really acknowledging, as I've already mentioned, that our work around hepatitis means we address larger systems issues. Intersectionality speaks to the different layers that we have to address in order to address hepatitis, whether it be racism, immigrant, migrant healthcare rights, LGBTQ rights, gender equity, all those pieces are part of our work. And finally, aloha. And not only the idea of aloha as love and that value, but the idea of place, that we live in Hawaii and that we recognize the values of the Native Hawaiian people and the land that we are on. You could see here too, I also like to point out there are quotes throughout our strategy, again, really lifting voices and stories as an important piece of our strategy. Next slide. How do we get here? I already mentioned we did this over 1 year. 120 different stakeholders plus, 160 actually. Wow. And I guess I was just kind of blocking that memory. And then over 24 formal meetings, not including informal meetings. An important piece of what we try to do is what I think many of you already do, but it's low threshold engagement. So usually planning processes like these really only are scheduled during work time, and it involves people who are already getting paid to do hepatitis work. And so the feedback from the community was, well, what about us? So things that we try to do where we paid community members to give feedback. We held meetings that were on weekends or after work so folks could join. We tried to create opportunities for folks to give feedback at any level. So as I mentioned, they could just text me. We could just do informal Zooms with no agenda. We had outreach workers just sitting at syringe exchange vans asking 2 questions. What do you know? What do you think should be done about hepatitis, and how does it impact your life? And they just give very informal feedback. So just really acknowledging there's multiple ways to engage and multiple layers of engagement, which we try to do. But through this long, iterative, messy process, our community members came up with 5 priorities for hepatitis elimination. You can see our wheel right here, and that's awareness, access, advocacy, equity in everything we do, and data for decision making. Another value or idea when we propose this, and I'll go over this a little bit more, is just that we embrace the idea of microelimination, which is that you could have multiple community-driven, community contextualized efforts going on at the same time that all contribute to this larger elimination. So next slide, please. So this is what the plan will show, and you can always look it up more in depth, but we identify the 5 priority areas. Under each one, we identify strategic directions. So not necessarily goals, but where do we want to head in the next 10 years, which allows for nimble action and for things like these micro elimination opportunities. So this is not a complete set, but it's really just ideas to generate, and also allowing us to fail fast. So if something's not working, we can move on and see what else is working for our communities. Next slide. So I'm not going to go over each one specifically, but just to show you each one. So this is the first one, awareness and education. You can see our 4 directions: digital presence, cultural engagement, creating a hub, and then a healthcare education. Next slide, please. This shows just some of the opportunities under each direction. And again, these are not comprehensive, but just ideas to generate thought. Next slide. For access services, this is kind of the medical ones that we are pretty familiar with doing this work: immunizations, testing, linkage, treatment, and prescriber capacity. Next slide. And these are just some of the opportunities for microelimination. Next slide, please. Advocacy, we heard a lot about that as well. These are just advocacy at all levels. So not only building up health department capacity, but building up community and provider advocates, and doing things around policy and insurance coverage. Next slide. And these are some of the opportunities. So next slide, please, is going to be equity in everything. And this is very intentional. We wanted this to be stated that it is a direction and a priority for us. You can see shared leadership, people first, reducing stigma, and data and as measuring equity is an important piece. And the next slide will show some of those opportunities. And next slide again, you could see finally data for decision making. And as a reminder, it's not just quantitative, but qualitative data. Next slide. And these are just some of the opportunities there. And next slide. And as we close out, a lot of times people will do the acknowledgements very quickly, but we just want to be intentional. Because this is a community-driven document, this is probably one of the most valuable parts of our strategy and our documents. Our mahalos and our thank yous to not only our steering committee members present, but also our historical folks who contributed in the past. And also, of course, to our storytellers again, I'm just going to say their names again, just to acknowledge them: Stacia, Jade and Max, Kenson and Rensley, Peter and Nga, Paige, Britt, and Eddie. So really amazing storytellers. Next slide. I mentioned the 160 people. I'm going to read all their names. Again, I will not do that to you, but if you can click through this slide and a couple more, we acknowledge all these people who contributed in any way, at any level, and including people who chose not to be named or who could not be named, people who come to a syringe exchange, or people who just did not want to be named. And of course, we end this as we opened with all of our loved ones and the people we do this work for, the people who've passed and all the people who continue to show strength and resilience. You can see that final voice there. Next slide, please. This is just the original logic model when we first started. So we've come very far. Next slide. And finally, these are calls to action. So what you can do to help support us and hopefully how we can support you is share our strategy, read it. You can always join our elimination work groups, even if you don't live in Hawaii. Follow us on social media. Always thank your legislators if they support you, and then become our partner agency. So just some quick action you can do. Next slide, please. And this is just the contact information if you want to reach out. I'm also going to be here till the end of the session at 5 p.m. But thank you for your time. And I think I'm going to turn it over to Lauren, my colleague Lauren. So thanks. Oh, and here's just a link.
Thank you so much, Thaddeus. I'd like to now introduce Lauren Orkis. Dr. Orkis leads the viral hepatitis prevention and surveillance activities at the viral hepatitis and is the viral hepatitis prevention coordinator at the Pennsylvania Department of Public Health. Dr. Orkis earns her epidemiology degree, her doctorate from the University of Pittsburgh Graduate School of Public Health in 2017. Previously, she served as an epidemiologist at Allegheny County Health Department and instructor at the University of Pittsburgh. She completed a CDC CSTE Applied Epidemiology Fellowship at the Pennsylvania Department of Health in 2013. Welcome, Dr. Orkis.
Thanks so much, Catherine. So as Catherine said, I'm the viral hepatitis prevention coordinator at the PA Department of Health. Thank you again for the invitation to present. Today, I'm going to be providing an overview of our elimination planning efforts thus far, which incorporate both hepatitis B and C. And just as a note, in comparison to some of the other jurisdictions you'll be hearing from this afternoon, Thaddeus already spoke, I just really admire and continue to learn from all of my co-presenters. I'd say Pennsylvania is still in the early stages in comparison of our elimination planning efforts. But I think we really intentionally ensured from the onset that we addressed both B and C at the initiation of our planning process. And for those of you that are more in the early stages of development, I'd encourage you to do the same. Next slide. So I just wanted to start with a quick timeline to give you a sense of where we're at with our efforts thus far. The Department of Health began viral hepatitis elimination planning formally in 2019 with a summit that we held in May of that year, attended by over 100 stakeholders from across our state, including some critical partners from, of course, the Hepatitis B Foundation and Hep B United. And it was with the leadership of really those Hep B partners that we were able to push for the inclusion of Hep B in the early stages of elimination planning, given we know that we'll have the most success going forward collectively as more of a unified front. So this slide here, of course, lists the activities of the Department of Health that we sort of were directly involved in, but I also really want to mention the critical establishment of our statewide coalition, Hep Free PA, that was started in 2019, led by many statewide partners, including Sherry Cohen and Catherine Freeland of the Hep B Foundation. So at the conclusion of our first large summit in 2019, I asked folks to nominate themselves to a planning committee. And we were really lucky to receive over 50 applications showing lots of enthusiasm for this work, and chose 28 members representing folks with both professional and lived experience with both B and or C. And, at this point, we're not as successful in recruiting folks with lived experience as we would like on our, first attempt at doing this. But we're still, of course, actively recruiting and attempting to involve patients in other ways that I think better meet people where they are currently, utilizing, some of the expertise and experience of other states, such as Hawaii and others that have really have been able to involve folks with lived experience much more efficiently. But the planning committee met in person in October 2019 to brainstorm our elimination plan components that would be necessary to include for elimination to be at all feasible in our state. So we asked our members of this planning committee to brainstorm really wide-reaching and even, pie in the sky type goals in this first session. And as a next step, we then opened up the opportunity to all willing stakeholders to participate in 4 work groups tasked with drafting goals and objectives for different subsections of the plan. And we convened these work groups in the winter spring 2020 conference call. And then in June of 2020, we virtually convened the planning committee again to review the full draft plan. And then in October, we held our first virtual meeting of the interagency hepatitis work group, which I'll describe in detail here next. Finally, we are hosting a second annual stakeholder meeting virtually next week, actually, to review the final draft plan and review ongoing work across the state in the era of COVID-19. Next slide, please. So I wanted to mention this interagency hepatitis work group because I'm really hopeful that it'll give us some really good momentum in 2021 to move this work forward and work on implementation planning, really. So the idea for this work group was born out of a discussion that we had in early 2020 with the PA Secretary of the Budget's office about our work around elimination planning. And to really complement the planning committee I mentioned previously, it's made up of mostly external partners. We wanted to create this interagency work group to guide internal hepatitis elimination planning. So the external partner planning committee helped to draft the elimination plan, of course, in 2020. And then one of our interagency work group's goals will be to review and finalize that elimination plan in 2021. Another goal of the work group will be to, as I said, develop an implementation and funding strategy to really better ensure the success of our plan, which we know will be difficult to fund. And this work group will provide an opportunity for interagency discussion about resource allocation and funding strategies for various elimination plan components. And then finally, we're just always encouraging the members of this interagency group to join in our biannual summit meetings. So we encourage interaction with our external partners as well. Next slide. So, as we move through this planning process, we need to continue to ask ourselves the ultimate question of whether elimination is feasible in our state. And of course, this answer is a resounding yes, but we need considerably more resources devoted to the effort for this to even be possible. Next slide. So as we really start to assess whether elimination is possible in Pennsylvania, we have to first assess burden of disease. So our plan addresses, of course, B and C, but with increased vaccination efforts that we're hoping to implement, we know that this can also positively affect hepatitis A. So I have a couple of just basic stats here to cover on A, B, and C. So in terms of Hep A, we know in 2019, over 650 Hep A cases were reported in our state. Prior to 2018, when we really started counting outbreak-associated cases, our state average was only 59. So just a stark increase. Since 2018, the majority of these Hep A cases report recent drug use and or homelessness. In terms of hepatitis B in Pennsylvania over the last several years, we've consistently averaged about 700 new confirmed chronic B cases per year. These stats are, of course, excluding Philadelphia, which conducts its own really excellent enhanced surveillance. We know Hep B is on the rise in neighboring jurisdictions, even though we're not seeing it currently across the state. West Virginia, of course, is experiencing increases in Hep B, as well as several other states. We know in the latter half of 2019, Philadelphia released a health advisory about an increase in acute Hep B related to injection drug use. So we know this could be seen more statewide in the near future. And then excluding Philadelphia again from our counts, our collection of race ethnicity data requires significant improvement, with over 65% missing race ethnicity in our 2019 data. But of the data we do collect, we know that those folks identifying as Black or Asian are more highly affected than white individuals. And then finally, pre-COVID-19, Hep C was the fourth most reported infectious disease beyond only influenza, chlamydia, and RSV in Pennsylvania. But Hep C is arguably more deadly and costly, of course, than those three other infectious conditions. Next slide. So just in terms of some visualizations, this graph highlights the magnitude of our Hep C case counts reported to the Department of Health each year. Cases of Hep C increasing between 2013 and 2017 and decreasing a bit since 2017. Next slide. So, nevertheless, for a number of reasons, we know these counts likely underestimate the actual burden of disease. Every reported case represents an estimated 14 unreported cases. You can click that again, Catherine. And then we estimate about 2% of Pennsylvanians, about 300,000 people, have ever been exposed, and 200,000, or about 1.5%, may be currently infected. And when we're, trying to get the message across about the importance of hepatitis, we talk about some of these statistics. We always bring up pre-COVID-19 Hep C killed more people than any other infectious disease in the US. You can click again, Catherine, sorry. And liver transplant, as a result, costs on average more than $500,000. So together, these viral hepatitides are deadly, costly, but ultimately preventable. Next slide. All right, so we know our state is currently bearing a considerable burden of disease as a result of several factors, including substance use disorders, but we know, of course, that elimination of Hep B and C is possible in the US through intensive efforts to vaccinate, screen, and treat viral hepatitis. But as many other states are in the same position, we're currently significantly under-resourced to achieve elimination. And we currently don't receive any state funding for viral hepatitis surveillance or programming, although some important advancements have occurred in recent years in our state related to Medicaid and corrections. The current federal funds we receive for viral hepatitis prevention are very limited. We don't currently receive any surveillance funds. I am the only Department of Health employee solely devoted to adult viral hepatitis. Next slide. In 2018, modeling was completed by a group called the Center for Disease Analysis Foundation to assess the effects of robust elimination strategies on Hep outcomes in PA. And this visualization of those statistics, I think, is quite powerful. The black line here shows our trajectory if we did nothing else but what we're doing right now. Liver-related deaths pretty much leveling off. And then the red line shows our trajectory with elimination plans implemented. And you see by 2030, the dramatic decreases in these important and costly outcomes. So specifically, this would amount to treating about 150,000 people by 2030. And the prevention, they think of about over 6,000 deaths. Next slide. Okay, so I just want to give you a sense of what we're including thus far in our draft elimination plan. Of course, again, we're including components to address hepatitis B and C. So I want to give you an overview of the sections of the plan, including the barriers that we know exist and how the proposed plan components address those barriers. The draft plan provides wide-reaching goals and objectives. Again, I had mentioned this, and we drafted the plan, with partners, knowing that these objectives are wide-reaching, and we wanted to make sure that they were wide-reaching to put it down on paper, really, no matter how difficult or far-reaching they might be. But we did not make our objectives SMART objectives. I just wanted to mention that, but we do intend to create SMART objectives in the future. Okay, so this first section, the prevention and education section, we know in terms of barriers, there's general lack of awareness of viral hepatitis in our state, and that's similar in other states. And folks have a lack of knowledge about personal status and the need to be tested. We also know it can be difficult for adults to get Hep A and B vaccine for various reasons in Pennsylvania. And decades of research support harm reduction for specifically syringe exchange, this is a successful method of preventing viral hepatitis. But we know that harm reduction services are grossly lacking in our state. Currently, syringe service programs are illegal in Pennsylvania beyond Pittsburgh and Philadelphia jurisdictions. So specifically, the draft plan proposes the creation of a large public awareness campaign that includes patient voices and a storytelling approach. And when approaching the interagency work group, we posed this question about potentially tagging on to existing public awareness campaigns to include Hep messaging as well. We also know there's a need to greatly expand Hep A and B vaccine coverage statewide through enhanced programming, so part of our plan addresses that as well. And finally, we can work to expand co-located Hep services in hopefully expanding harm reduction settings. Next slide. Okay, so in the testing and linkage to care subsection of the plan, we've identified plan components to address barriers such as lack of patient awareness of their Hep B and or C status, the lack of universal screening statewide, and we know that Hep C reflex testing is also an issue. As we know, that first test, the Hep C antibody test, can be much easier for clinics to complete in certain settings, but the blood draw can be a difficult next step, and thus difficult to complete Hep B testing for that same reason in certain settings. So addressing the blood draw issue will be helpful for both B and C, of course. And finally, patient navigation through Hep services is lacking in many parts of our state, leaving people with just an antibody test result or unable to seek further evaluation. So our draft plan includes objectives to improve diagnostic tools and system-wide approaches. The plan also includes an objective to mandate HCV reflex testing in certain lab settings. And finally, the plan lays out some objectives related to increasing the availability of peer navigation, as we know this type of navigation really does increase the success of gaining access to all necessary services and gaining treatment and achieving cure, of course, for Hep C. Next slide. Okay, so for the treatment access section of the plan, we know in our state there are many barriers to treatment for both hepatitis B and C, including insurance and reimbursement issues, especially in certain behavioral health settings. We also know that we need to increase the number of healthcare providers able to treat both B and C to meet demands. And there are ways that we think we can tap into existing training programs to expand the availability of these services more statewide for both B and C. The draft plan includes an objective to also remove our Medicaid prior authorization process for Hep C treatment. That's been a real push from a lot of our external stakeholders. So in the coming months, we'll be working closely with our Medicaid representatives that are serving on our interagency work group to really assess this component in a really comprehensive way and figure out a way for us to move forward. Next slide. So finally, we have a long way to go really on our viral hepatitis data and surveillance side of things, at least from our health department's perspective. We lack statewide data to monitor the continuum of care for both Hep B and C. And through the collaboration of our interagency hepatitis work group, I'm really hopeful that we'll be able to increase our ability to monitor the care cascade as well as, and care continuum for Hep B, as we also want to monitor more routinely morbidity and mortality through additional data sharing efforts that have been not possible in the past. We also really want to be able to increase the amount of publicly available data for stakeholders in the public to monitor our elimination progress. Next slide. Okay, so finally, as we continue to work with internal and external stakeholders on elimination planning, we know implementation planning and figuring out those funding strategies will need to be a focus moving forward for our elimination planning efforts to be a success. I just wanted to highlight here an example of interagency collaboration that we are hopeful will help us move towards our elimination goals. So the State Opioid Response Grant's Year 3 iteration includes a section to improve prevention, testing, and linkage for HIV and Hep A, B, and C services in drug and alcohol treatment facilities. So the Pennsylvania Drug and Alcohol Program partners approached the Department of Health about collaboration on this particular section of the grant, and we expect this section to be funded for about 2 years at $1 million a year, which is an amazing amount of money for us to tackle some really important issues. Many of you may also be involved in this work in your state as well. I just wanted to highlight that this is a really good example of how we'll be able to use integrated grant funding to address some of our elimination plan goals and objectives. And we're hopeful that these funds will be extended even beyond the proposed 2 years. And we'll continue to work with additional agencies through our interagency work group to identify similar avenues for collaboration using integrated grant dollars. Next slide. So thank you again for the opportunity to present, and I would be happy to answer questions at the end.
Great. Thank you so much, Lauren, for that really great presentation about the status of Pennsylvania. So now we'll be hearing from New York, and we'll learn about where they are. I'd like to now introduce Jessie Schwartz, who's a program director in the New York City Health Department's viral hepatitis program, where she currently manages a project integrating overdose prevention interventions into health department's viral hepatitis community navigation programs. From 2016 to 2019, she managed a pilot research program to improve access to hepatitis B care for women identified with hepatitis B during pregnancy. Prior to joining the health department in 2014, she worked for 10 years as a critical care nurse at New York Presbyterian Hospital. Working as a nurse both pre and post passage of the Affordable Care Act gave her the unique experience of seeing how government policy can profoundly impact people's lives, and made her passionate about improving access to quality healthcare for all people. Thank you so much, Jessie, for your work, and I'd like to welcome you now to present.
Okay, thanks so much. Hi, everyone. If I'm smiling, it's because I'm like flooded with serotonin, seeing all your beautiful faces that aren't my immediate family. So happy to see you all. That was a great introduction. I don't think I need to say any more. Next slide. So just to let you know, to paraphrase a famous 80s movie, I'm only talking about Hep B today because nobody puts Hep B in a corner. So no Hep C or A in my presentation. Such a corny reference, but had to do it. Okay, so a little bit about Hep B in New York City. There's approximately 241,000 people living with Hep B in New York City. We estimate locally about 46% remain undiagnosed, and nearly 6,000 people were newly reported with hepatitis B in New York City in 2019. Next slide. What do we know about people newly reported? So like Lauren, we don't have great demographics for all of our surveillance reports, but we do know their age. Most are between the age of 30 and 59. The neighborhoods with the highest rates of Hep B also have large immigrant populations. Nearly half are in high or very high poverty neighborhoods. And for the program where we do have good data, the perinatal Hep B prevention program, nearly 100% of the women identified or people identified with Hep B were born outside of the US. Next slide. So Hep B elimination in NYC. This is a map of people newly reported with hepatitis B every year. So if the previous slides didn't paint the picture for you, we have a lot of Hep B in New York City. So in 2016, the World Health Organization proposed goals for global elimination. That was a 90% reduction in new cases of chronic hepatitis B and a 65% reduction in mortality due to hepatitis B. Just a few things, because in New York City, most of the hepatitis B is coming in from other places, so it's mostly immigrants. In terms of prevention and vaccination, we're not sure how much of an impact we can really have on new cases, but I think that we can have an impact on the lives of people living with Hep B in New York City or coming to New York City with Hep B. So if you go to the next slide, what we thought about is like, how do we get there? If it's not elimination, perhaps it's eliminating the negative health consequences, eliminating the racial and ethnic disparities in liver cancer, and things like that. So this has been great watching the two presentations before mine, because I think it's like a Marxist quote, like from each according to her ability, for each according to her needs. So I just got a lot of great ideas from Thaddeus and from Lauren about what their jurisdictions have done, and both of them have a really unique approach and will inform the work we're doing here. But what we do have in New York City is a great, very strong surveillance system. So we kind of started from a different place, thinking, how can we use our data to see whatever we do, or whatever the community tells us we should do or does themselves, or whatever we collaborate on, how can we tell if it's having the impact we want it to have? So we came up with just a very general framework of how, using our existing data systems, we might be able to monitor our own progress towards Hep B elimination. So next slide. Our first goal, and we're behind both Pennsylvania and Hawaii in this respect, is to convene a multi-sector collaborative stakeholder work group to develop the viral hepatitis. So this is the only reference to C. Sorry, I should have taken it out. B and C elimination plan, approach, strategies, activities, and to agree upon indicators. So we're thinking it'll take about 16 months to complete this process. I think Thaddeus said, I think you each said about a year it took for you to get started. So hopefully we can get this started. Of course, with COVID, everything's a little more behind what we would like it to be, but you know, that's the world we're living in now. Next slide. So our second goal would be reducing deaths and improving the health of people living with Hep B. So the percent of people living with Hep B who die prematurely. So premature mortality has been gaining interest as an indicator in New York City, as opposed to just whether you die of hepatitis B related causes at any age. First, because on death certificates, it's often underreported, and so it might not be the best indicator. And secondly, if someone dies at a very old age with Hep B, it's not quite the same, you know, as someone who dies at the age of 50 or at the age of 40 or something like that. The National Academies of Sciences, Engineering, and Medicine put out a plan where they estimated if all these goals were met, that we could reduce total mortality related to Hep B infection by 50%. So that's 90% diagnosed, 90% linked to care, and 80% of those in need of treatment start treatment. Next slide. So we tried to think through these indicators locally based on the data we have available. So we propose a 65% reduction in premature mortality for people with Hep B. So we would use our surveillance data matched with vital statistics. The current baseline from 2017, as I mentioned before, was 45.5%. So the 2030 goal, a reduction of 65%, would be 31%. Premature mortality, which you really don't want to see any, but that would be a reduction. 90% are screened. So surveillance data is just positive reports, not negative reports in New York City. I'm not sure what other jurisdictions collect. So what we've been doing is working with our community navigation programs, other partners, and giving them a standard way to report their screening data to us. So we started to pilot this with the Check Hep B community navigation programs, which are our local hepatitis B navigation programs. And overall, they reported 57% of those at risk were screened in 2018. So we're hoping to get more organizations measuring this, first of all, and looking at it so they can improve it. And secondly, sharing that information with us so we can get a better gauge at how well we're doing with screening, with the goal by 2030, of course, being 90% screened. The last one is that 80% of people diagnosed with hepatitis B for at least 1 year and are greater than the age of 40 are virally suppressed, a viral load of 2,000. So this indicator we're going to discuss with the community as part of the elimination planning process, and I'm sure it will change or be improved. But the reason we came up with this is because surveillance data is fairly limited. We receive DNA reports, are the primary report we get, along with surface antigen. We receive negative DNA, positive DNA, and the actual level positive E antigen. We don't get negative E antigen currently. And like I said, other negative results we don't receive either, and we don't receive ALT. So we looked through the data and referenced several large reviews, and it seemed to be that the ages of 40 and 50 seemed to be the ages when rates of end-stage liver disease, hepatocellular carcinoma, they started to really climb. So we think that's a good age where high levels of DNA would be the most risky for people, and we really want them to be treated by that age if they have high levels of DNA. So that's why that is put in there, but it might change, of course, over time when we speak with different people in the community and get feedback from physicians and providers. Next slide. So next, we want to make sure we reduce health disparities and that we can measure and report that we are reducing health disparities related to Hep B infection. So New York City residents who identify as Asian and Pacific Islander have 7 times the rate of death from hepatitis B infection as compared to white residents. There's likely disparities in access to good care across the 5 counties that make up New York City. And community navigation programs report many patients without health insurance don't have access to ongoing liver cancer surveillance, even when recommended by a medical provider. Next slide. So these are some proposed indicators related to addressing health disparities with Hep B infection. So an 85% reduction in rates of overall mortality from hepatitis B for Asian and Pacific Islander residents. So right now it's 2.2 per 100,000. To reduce that to 0.3. Once again, we'd be using surveillance data matched to vital statistics. So there's something called neighborhood tabulation areas, which we are using to report information that's more similar to neighborhoods as opposed to a zip code or a ZICTA. In New York City, I'm not sure if that's, I actually don't know enough to know if that's specific to New York City or if this is a national way that you can measure a neighborhood as opposed to a zip code or a county. But because population density is so great in New York City, at least it was before COVID, we'll see when things open up again what it looks like here. NTA was a way that we could look at what was happening in a specific neighborhood, because a neighborhood here is hundreds of thousands of people. I mean, it's the same as a small city somewhere else oftentimes. So what we want to look at is that, are people being treated more in one neighborhood than another, and use that as a proxy for good access to care in different parts of the city, because the city is differentiate by income and other types of things. So we want to see equal rates of treatment across neighborhoods in New York City. And we also want to see that everyone has access to regular liver cancer surveillance. So there are programs for colon cancer screening, for cervical cancer screening, for breast cancer screening surveillance for people who don't have access to health insurance. But unfortunately, there's no similar federally funded program for people with chronic hepatitis B. So we are asking our community navigation programs to report when people have access to liver cancer screening, and hopefully develop a way to report out the number and percent of people that don't have access to this when recommended by a physician. We haven't started collecting that data in the way we would need for this yet, but it's something we're planning on doing. Next slide. So our current response, we have the perinatal Hep B prevention program. We monitor hospitals to assess coverage of the Hep B birth dose. We have an internal health department navigation program that does outreach and linkage to care. We work with our community partners to assess Hep B screening rates. We're developing a patient navigation training and resources to share with programs in New York City. Next slide. We have some city council funded patient navigation programs at 6 hospitals, 3 health centers, and 3 community organizations. They reached over 1,500 people living with Hep B last year. And we provide training through Empire Liver Foundation and other partners to healthcare providers on evidence-based screening and treatment for hepatitis B, including pregnant women. Next slide. Just to acknowledge that there are many, many systemic barriers to elimination. Hep B affects a largely immigrant community in New York City, many of whom are considered non-white, and they experience both racial and anti-immigrant discrimination. Also, mentioned in my introduction that I was working in hospitals during the Affordable Care Act, and I think one negative thing that came out of that is that there's a group of immigrants who have even less access to health services than they had pre-ACA, because pre-ACA, a lot more people didn't have insurance and there were a lot more safety net programs. And now a lot of those are being eliminated. And it's sort of making it even harder for certain groups to access health services. Although we do have public hospitals, FQHCs, other providers that offer low-cost services, they're often very difficult to find out about, very difficult to access. You may have to go to an in-person appointment just to enroll in low-cost services separate from your health appointment, language barriers, other types of things. And community advocacy is needed in New York City to ensure all people have access to services to maintain their health and receive treatment for illness. Next slide. That's it. And there's Angelica Bokor. I put her email. If anyone is interested in surveillance or using surveillance data, she would be the person to reach out to. And of course, Nira, who does all of the community navigation program work.
Great. Thank you so much, Jessie. That was a great presentation and an overview of what you guys have been working on in New York City. Next, I'd like to invite Batima Reed to share a bit from NASTAD. Batima is the director of hepatitis at NASTAD, and as the director, she leads the organization's viral hepatitis programmatic activities, including the design and implementation of a national technical assistance center to support viral hepatitis surveillance, testing, prevention, and treatment programs at state and local health departments. Prior to joining NASTAD, Batima was the chief of the Center for Viral Hepatitis at the Maryland Department of Health, where she coordinated departmental and statewide efforts to prevent, control, and treat viral hepatitis. She's also worked in public health at both the federal and local levels and practiced health law as an attorney that focused on HIV legal services. I'd like to now welcome Batima to join. And just a reminder, if you have any questions for Lauren and Thaddeus, be sure to type them in the question box. They do have to leave now, but I want to thank Thaddeus and Lauren before you have to leave, to both of you for being here with us today and sharing about your elimination plans.
All right, thank you so much, Catherine. And thank you definitely to Thaddeus, to Lauren, and to Jessie, to all of the folks that you are engaging in this work with, including who are on the line and across the country. And also just want to acknowledge all the folks all over who might be doing some informal elimination planning for those of you who need some energy or a push, who are trying to meet with your decision makers and you're just not getting that support, or trying to meet with your leadership and you're not getting that support. Please know that all of the panelists today, I'm speaking on behalf of folks, but I'm almost certain they would agree. We're thinking about elimination planning and planning for elimination planning long before getting to the point of building that coalition and actually developing the plan. So just know, like, the fight continues, you are well supported, but also don't feel overly intimidated by the fact that there are all of these published or almost published plans and you're in the early stages. You will get there. Just keep fighting the good fight. So with that, I'm going to skip through a little bit. I almost feel like my presentation will be kind of summarizing some of the conversations we've had and might just informally add some anecdotes along the way. So bear with me. I'll also try to wrap this up a little faster so we can get a little rest as we jump into day 3 of the meeting. So I'll start off. For anyone who's not familiar with NASDAD, I can briefly say we were founded back in 1992. We're based in DC, and we really focus on providing technical assistance and capacity building to viral hepatitis, HIV, and harm reduction programs across the country. And we do it in a very collaborative way. We also are consistently working on and thinking about policy and advocacy and how changes to policy and advocacy really can drive the efforts that you're hearing about today and a number of other efforts that are happening in our infectious disease programs at health departments. Next slide. All right, so I'm just going to go through a few things. I wouldn't even pretend to touch on hepatitis surveillance in the same way that Dr. Carolyn Wester did in the earlier federal panel, along with Carol Jimenez and Jessica Deeren. But there are a few points that I wanted to just bring up really quickly. So if we can go to the next slide, perfect. So this is actually a point that was raised by Lauren. And so it's one that I'll go through very quickly. But when we look at this table, so this is a table from the CDC's Viral Hepatitis Surveillance Report for 2018, the most recent year for which data were available at the time of this report. We see that in terms of reported cases nationwide for acute hepatitis B, there were about 3,300. But when CDC accounted for underreporting and other factors, it turns out that those cases probably look something closer to, or those individuals with acute hepatitis B, it was closer to around 21,600. That is a significant difference in terms of the folks who are actually dealing with acute as well as chronic infection. Also want to note at this time that there's a significant need for us to transition into a much more advanced hepatitis surveillance system nationally. So within the jurisdictional, within individual jurisdictions and nationally, really see an advancement in our viral hepatitis system, because we need to really know what's actually happening when it comes to hepatitis B, as well as C and A. So that's one of the things that I wanted to point out here. Another thing that I wanted to point out is that we're not seeing significant increases, but we're also not seeing significant decreases, which really points to the fact that we have some really important work to do when it comes to hepatitis B. Next slide. I wanted to briefly show this slide again from the CDC's 2018 surveillance report and highlight one thing in particular, and that is that amongst the jurisdictions, so among the states that you see listed here, within the top 10 that had the highest reported cases of acute hepatitis B, we see that about 4 of those states, at least 4 of those states within the top 10, actually also had the highest rates of overdose deaths at that same time. So when we talk about the intersection between our opioid epidemic, chaotic drug use resulting in overdose death, and its intersection with infectious diseases, specifically viral hepatitis, it reigns true for hepatitis B. And we really do need to be more thoughtful about how our harm reduction efforts integrate specifically hepatitis A and B vaccination, as well as access to quality care and treatment. Next slide. I also wanted to quickly highlight the importance of it. At this time, we just see that issues of race, of racism, discrimination, xenophobia are often, I apologize, politicized and made to seem as if it is something that is up for debate. But just like Thaddeus spoke to, the data don't lie. They're here, and they're telling us that even when we see, for in this case, reported acute hepatitis B, even when we're seeing decreases amongst white non-Hispanics, we're not seeing those same changes for communities of color, which doesn't tell us, which essentially tells us that this is not a political issue. This is an issue of need. And if we are actually focusing our programs in a way that's designed to effectively change the impact of acute hepatitis B as well as chronic hepatitis B in our nation, then we need to really focus on those communities that are disparately impacted and where we're seeing increases when we should be seeing decreases given how resource rich of a nation we are. Next slide. Something I'll just very quickly point out is, again, getting to that need for enhanced surveillance. For those who don't know, currently we only have 14 jurisdictions that are funded for comprehensive viral hepatitis surveillance. As you heard from Dr. Wester earlier today, we're transitioning into this period in 2021 where that will move from 14 to 58 jurisdictions. If you need anything to help you understand a little bit more about the importance of that move, this slide should help to do that. Of the reported cases of acute hepatitis B from 2018, I think it was about 74% of them do not have risk factor data or information about potential exposures included. And so it's more than time for us to really be able to advance our hepatitis surveillance capacity across the country so that we can more effectively address this. So why would I raise all of this before I go into a conversation about elimination? I'm saying it to say that if we bring together all of these efforts, if we think about all the folks who are participating in the Hepatitis B Summit, there is no question that you're having an impact in this moment on this day and every day that you log onto your computer, step into your office, see your patients. There's no question. If we ramp up those efforts, we will continue to have an impact. The problem is that if we do that and we don't have a surveillance system to match it, then how do we actually know how we're doing? That's one of the big issues that we've got to be able to tackle as we go into our elimination work. Next slide. All right, and I'll jump into the next slide. All right, so one of the things that I want to make sure I say, and I promise you I'm going to try to wrap up my presentation because I know we've hit that 5 o'clock hour, but one of the things that I want to make sure to say during our time today is that we really are not guaranteed an opportunity like the one that we have right now. Granted, it's been changed a bit by the fact that we're in the middle of a global pandemic, but prior to the pandemic, and this continues to stand true, we had the WHO strategy to eliminate viral hepatitis come through. And this was a resolution that was universally or unanimously adopted. So this was one that all nations said that they could get behind. And so one of the things that I always want to make sure that people know is that the US was among those nations that unanimously decided to move forward. We are not in a position where we might potentially have another opportunity to do elimination for B or for C. The reason we have to talk about integrated planning, not only because there is such significant overlap in terms of populations that are impacted by viral hepatitis across B, C, and A, and in some cases Delta as well, but also because we have this unique opportunity where not only have our global partners agreed to and committed to viral hepatitis elimination, but we as a nation have done the same. And something I'd also like to point out is that Jesse spoke earlier to the NASEM report and what the type of accomplishment we could make if we actually implemented the hepatitis B specific strategies within the World Health Organization's strategy to eliminate hepatitis. By 2030, we could avert 60,000 deaths in our nation alone if we take the time to effectively implement these strategies. But then, of course, that begs the question, next slide, about how we're doing. And as it currently stands, based on an analysis done again by the Centers for Disease Analysis, so these are the same folks that Dr. Orkis in Pennsylvania worked with, they actually did some modeling to see how we were doing. And what they found was that sustaining things as of 2017, so looking at the status quo in 2017, if we maintain that status quo, so if we don't see a significant ramp up in our efforts to eliminate viral hepatitis, 80% of high income nations will not achieve the 2030 goals. And even worse than that, 67% are projected not to have met those goals by 2050. So even 20 years after the 2030 mark. Something that's important to note is that the United States is among those nations that are expected not to even meet these goals, these 2030 goals by 2050. That again is if we maintain the status quo. And so that takes me to the next slide. That status quo is so important for us to recognize, because we're not a people of maintaining the status quo. We are a people of finding a way out of no way, and making waves where waves need to be made in order to save lives. And so one of the other things that the Centers for Disease Analysis has done, and that I will continue to highlight because I think they really hit on some of the most critical points, is to look at those factors that are critical to achievement of our global 2030 elimination goals, on a global scale and on a national scale. And the 8 factors that they identified were political will. So we've heard that discussed with the elimination plans today, that there has to be leadership that's really buying into and supporting the development of these elimination plans, as well as their implementation. Additionally, financing the program. We heard from our speakers, including Lauren Orkis, who was talking about unique ways that they're looking at being able to support the activities that they've outlined in their elimination plan. Also implementing comprehensive harm reduction programs. So ensuring that SSPs are legal, that SSPs have comprehensive services, are well funded. And during the COVID-19 pandemic, we have seen a number of SSPs across our country close. We've also seen some jurisdictions start to backtrack on the legalization of SSPs. There's a lot of work that has to be done, and SSPs really are critical to our hepatitis elimination efforts. Also expanding capacity beyond specialists. We have significant evidence demonstrating to us that primary care providers can just as effectively treat and cure hepatitis C. They can also effectively treat hepatitis B. They are critical to diagnosis of hepatitis B and C. We have to engage providers at all levels. Additionally, removing treatment restrictions. You heard in all of the plans that there's active work with Medicaid programs in order to remove things like sobriety restrictions, arduous prior authorization processes, so that we can make it easier for people to be able to access treatment, and also recognizing that prevention also reduces transmission. So by treating people, we are treatment reduces transmission. So by treating people, by curing people, we are reducing onward transmission. Then the additional pieces, they include implementing monitoring and evaluation, implementing awareness and screening programs, and implementing linkage to care. All efforts that you've seen integrated in all of the plans that we've discussed today. Next slide. All right, so as I go through these next slides, I'm going to take it through pretty quickly so that I can get us off pretty soon, or take any questions that you have. But I want to highlight the fact that when we're talking about status quo, it is not as if we have not had ongoing strategies in this nation. As I mentioned, the folks who have presented so far, so Jesse, Lauren, and Thaddeus, have long been engaged in work with colleagues, with those of you on the line, in order to eliminate viral hepatitis. It's been about naming it and really having a coordinated response in order to eliminate hepatitis. But we also have a number of guidance documents that sit with us in the United States to really lead those efforts. Next slide. But one of the most phenomenal ways in which our federal government has actually named the need for a coordinated plan for hepatitis elimination is through the development of the strategic plan that was presented earlier in this meeting. And I really just want to highlight that it is going to take significant advocacy and coordinated efforts with our federal partners to see that this plan is appropriately funded and implemented. And so truly supporting HHS in that work and supporting one another in our national efforts and our local efforts. Next slide. Additionally, recognizing opportunities for us to coordinate across our health departments and with community partners through this upcoming NOFO from CDC. I won't go into details because Dr. Carolyn Wester talked about it earlier, but this really is, again, going from 14 jurisdictions to 58 jurisdictions funded to receive hepatitis surveillance as well as prevention, and including an opportunity for work in high impact settings like SSPs. Next slide. So I'm going to end my presentation by quickly talking about what we've learned at NASTAD and some efforts we're undertaking to keep you updated. In 2018, NASTAD initiated implementation of a hepatitis technical assistance center through a cooperative agreement with CDC. In addition to that, we didn't want to jump into it and not be as informed as we could be about what the needs are of our health department viral hepatitis programs. So we conducted a needs assessment. Next slide. Thank you. And within that needs assessment, one of the things that we looked at was actually asking jurisdictions how things were going around elimination planning. What we learned was that of the 43 jurisdictions that completed the assessment, about 40% of them said they had a strategic or elimination plan. Now, what we learned along the way is that some of those strategic plans might have been written 10 years ago, but at least there had been an effort to develop a plan. And also in terms of elimination plans, there were some efforts to move on them, but they hadn't been able to get that buy-in to finalize the plan. One of the things that I really want to highlight is that we have over 20 jurisdictions in our nation and counting that are engaged in elimination planning, including jurisdictions with published plans. The ones that you see here with an asterisk have been funded by ASTO, and so many of them are continuing to work through that. And of course, that includes Pennsylvania. But something that I really want to talk about in terms of a best practice is one, your plan should integrate hepatitis B and C. It's something you have to push. One of the big reasons that people outside of the hepatitis world are decision makers that leads them towards hepatitis C is they've heard of the cure. They've heard of the cure, therefore it means that we can cure everybody and hepatitis C will be gone. But the reality is that we know there's so many other pieces to that. There's the harm reduction piece. There's the lack of access to care, the restrictions that are preventing access to curative therapy, but also they may not know and they may not recognize that hepatitis B is vaccine preventable, that hepatitis A is vaccine preventable, and that we have this really unique opportunity to integrate them in order to address viral hepatitis elimination broadly. Second, as we're looking at promising practices and best practices within our jurisdictions, you've heard from each one of our speakers that none of them are doing this alone. They are doing it in coordination with community, doing it in coordination with individuals with lived experience. So if you take nothing away from this panel, which I think would be impossible, but if you take nothing else away, please recognize that just like we're seeing on the federal level with the national strategy, speaking to the importance of bringing together all stakeholders, it's going to take the same level of coordination and collaboration at the local and state levels in order to develop effective plans. And if it needs to be any clearer, for anyone who you're working with who doesn't understand the importance of building out these plans with community, it's recognizing that there's no way your health department is going to implement this plan alone. It's going to take those partners. So rather than introduce them at the point of implementation, introduce them at the point of planning so that you can more effectively implement. With that, I'll just wrap up by saying, my last slide covers COVID-19, and I won't go into, we all know what the impact of COVID-19 has been, but something I do want to acknowledge is the significant impact it has had on health department staff, and the fact that our infectious disease folks, particularly our viral hepatitis coordinators, surveillance folks, hepatitis B coordinators, they are known for the significant and impactful work they've been able to do with minimal resources to address infectious disease, and are among the health department staff that are being called upon the most as we are responding to COVID-19. Still, they are effectively engaging in elimination planning. They're still effectively engaging in hepatitis response. So I say all that to say, be kind to your health department folks, reach out to them. If you don't hear back, follow up with them, but recognize that they hear you, they want to continue in this coordination with you. They might just be pulled in a number of different directions, but I am certain that especially as we're thinking about how to integrate our COVID-19 work and our viral hepatitis work, that we will effectively get to reaching our elimination goals. With that, I just want to thank you for the opportunity and for sticking around until 5:13, and look forward to working with everyone going forward and going through the next part of the meeting.
Great. Thank you so much, Fatima. You did a great job summarizing really a lot of the key themes and overarching themes really at state, national, and city levels. You brought up some really important points: the opioid epidemic, harm reduction, systemic racism, COVID-19, and all of these things that we're facing right now in the space of viral hepatitis, and then those challenges layered on top of eliminating viral hepatitis at our state levels, which are all really challenges that we all need to think about as we're creating these plans. I hope that you guys have maybe a couple minutes for a couple questions. Is that okay, Jesse and Fatima? Awesome, great, thank you. We do have a question in the chat box that's asking for recommendations or suggestions for plans that are coming out that are just focusing on hepatitis C, and how we might be able to work to engage with those partners to be sure that hepatitis B is also included within those plans.
So I can throw out a couple thoughts early on, because I don't at all intend to make it sound like it's a easy or light thing to do. So if you are, if you are early in the planning stages and there's an opportunity to, and you're really the person who is writing down those first initial thoughts and drafts, please make sure that you are thinking about approaching it as B and C. But for those of you who are in jurisdictions where you might be in a situation where leadership is actually saying, hey, we're thinking about hepatitis C elimination, we want you to work with us on that. Or if you are a partner who is working with a health department that's drafting it, or a coalition that's drafting it, and they're looking at a specific focus on C, one of the most important things that you can do is what Thaddeus mentioned, which is really bringing the data to them and letting the data speak for itself, and the importance of taking an integrated approach to B and C. A lot of times when people a lot of people don't recognize, I know this sounds silly to say, but a lot of people don't recognize the impact of hepatitis B. They often hear about C, they don't hear about B. So the numbers present a really awesome opportunity. Also, a lot of decision makers don't like things that they can't do something about. So really leading with the fact that hepatitis B is vaccine preventable and that we have effective treatment, talking about the significant research profile that hepatitis B has within the NIH, those are the things that are going to grab their attention and make them recognize that if they integrate hepatitis B, there's an opportunity to be successful, that there are targets that they can actually meet. So those are just a few initial thoughts.
Great point. Thank you. Jesse, anything to add to that?
Yes, I agree completely. Fatima, hi, nice to see you all again. See, still happy. I agree. I find that when I am at my feistiest at the health department is with Hep B, because people really overlook it. I say they don't know what Hep B is, and they only found out about Hep C 4 years ago. And that's basically what we're dealing with at the health department. And so I think it is a human rights issue. It's something that can't be overlooked. I think liver cancer rates are going up. It's a deadly disease. One person dying at the age of 40 from liver cancer that can be prevented is unacceptable. And it's, it's one of those areas where you have to speak up for people who can't speak up for themselves, and you have to be a real advocate. And you might pick your battles, but this would be the battle I would pick working in viral hepatitis.
Great, thank you. I think another strategy too that might be helpful is, figuring out the community that the organization serves that you're going to, and saying this definitely affects your community as well, especially if you're thinking about integrating into the harm reduction space. I think Fatima and Jesse, you guys are right. People don't know about it, and they don't know that it affects their communities too. And so educating them on that, I think, is so important. I wonder what strategies or suggestions you might have for someone just getting started with this. Say they, have thought about starting an elimination plan, but don't know where to start. They don't know how to get their health department on board. What suggestions might you give to them to kind of get the ball rolling on that? Jesse, would you like to take a start? Sorry.
Well, I don't know that I have the historical context locally, like someone like Nira, who was doing the Hep B coalition in New York City for a long time. But I would say, there's there's some groups locally that have been addressing this for a long time. In New York City, Charles B. Wong Community Health Center, there's African Services Committee, a few. I would start somewhere like that, a community-based organization or health center that likely has been doing this work for 20 years, you know, or something. And that would be where I would start.
Jesse's absolutely right, especially if you feel like you're in a jurisdiction where your health department is not taking this on. Of course, I would encourage you to reach out to your hepatitis coordinator or your infectious disease folks and see what they're doing. As I said, if you don't hear from them right away right now, it might require some follow-up due to COVID response. But I also think that there's a unique opportunity through participating through meetings like this. So there are a lot of national partners, including the leadership on this summit, who are talking to folks across jurisdictions, and they're talking to organizations across jurisdictions, and they know providers, and they know community-based organizations. And so where you might kind of be saying, I don't even know where to start, some of those conversations have already been started. It's just a matter of figuring out which door to go in order to really engage and get in coalition with folks who are engaged in hepatitis elimination efforts, or at least thinking about how to get there.
Great suggestions. Yeah, I think connecting with people who are on the call now, who are at the summit, to learn from their experiences. We've seen some great presentations today that have highlighted a variety of experiences and stages of the development of elimination planning. So I think that's a great point. One other thing that I'd like to touch on is the importance of policymakers. You all talked about how it's important to get their buy-in. Do you have specific suggestions or strategies that you have used that have worked really well to get their buy-in and get them engaged in the planning process? Batma, do you want to go first?
Sure. So there are so many different approaches, and my mind is like going in a million different directions. So I think I'll just go to my experience in Maryland, which was the importance of coalitions and also identifying champions. So if you are already actively involved with Hepatitis B Foundation and Hep B United, you hear this. If you are somebody who is living with hepatitis, telling your story is so critical, especially as a constituent, and reaching out to policymakers in your jurisdiction or even at the national level. But also working with your coalition, if you have one, if you have a formal one, or if you don't, working with other groups, other folks who have a vested interest in viral hepatitis, and really making a coordinated effort, especially on advocacy days, to get in front of them, to really write them, to hold them accountable, and also having a conversation. Rachel McLean from California recently talked about this, where there are so many things as a bureaucrat that a health department person might not be able to say or do, but it doesn't mean they don't have ideas. And so being able to have a conversation with them and see where they might have identified that there's an interest by the legislature, but they don't know whether to go left or to go right. And here's an opportunity for you to get in front of them, testify. I tell folks that all the time. You might not recognize it, but I have actually seen in committee at the state level where a single testimony can really turn the tide on something that's being considered by the legislature. Or when I was in Maryland, it was our coalition who brought it to the legislature and said, we want to see you get rid of your Medicaid restrictions and provide funding to the state to address viral hepatitis. And it didn't happen in the first, second, or third, or fourth session, but it did happen. And now there's an increase in funding that had never existed. It had never been a state-funded program, viral hepatitis program, and now it is. So just have faith that you actually can drive policy.
Thank you. Jesse, anything to add to that?
No, I think Batma did an excellent job. I did see one question pop up into the chat about EMR though, which maybe
sure, go ahead.
Mention something. So like I said, we've been using, developed like a standard way for people to report screening data to us using the EMR. The problem is people are not collecting good demographic data about their patients, which is relevant to their health status and the screenings they need to receive. Someone born in different parts of the world needs different types of screenings in healthcare. So it should be documented for valid health purposes, not just for the collection of data. So that's one thing I really think needs to happen more broadly across this country, is you really need to be getting a whole picture of your patient and treating your whole patient and not overlooking the demographic factors, which are important. And I'm talking about place of birth, also any unmet needs you have related to housing, transportation. This should all be included in an assessment and documented in a structured way so you can see what your patients need and meet those needs. So we do have a screening tool. It's not great. It relies mostly on a combination of race, ethnicity, language, country of birth where available, that type of thing.
Thank you. Any last thoughts on that one, Fatima, to add?
The only thing I would say really quickly is that there were actually a number of really great presentations during the summit last year on hepatitis B screening and use of the EMR for effective hepatitis B screening. So I'm not sure if those presentations are still available, but if so, I think those would be extremely helpful. And if not, we can connect you with the folks who did those presentations.
Yeah,
I think
definitely.
Sue Wang maybe did one. Was that correct? Yeah, that was a good one.
And UC Davis, Dr. Moon Chen also had some interesting strategies as well from California that they were implementing. But yeah, there's been several examples, and I think that that's a great point. And I would, again, just encourage you to reach out. Both of those people are, or there's a representative from UC Davis, there's representative from St. Barnabas, and Sue herself has been attending some of these sessions. So reach out to those people. Karen, I know you asked that question, or others. If you're interested in learning more, I'm sure they'll send you their poster or their presentations from last year, or what they've been doing recently, because I know they've adapted some of those methods recently to make some of those lessons learned changes and overcome those. But I want to be mindful of our time, and I want to thank each of you for staying a little bit longer for us today. I know we ran over a little bit, but I wanted to thank you for that. Thanks to the speakers, and thanks to Jesse and Fatima for sticking around and answering some of the questions that we had come through. I want to also remind each of you that the virtual platform is still open. You can go attend the sponsor booths, you can look at the posters still there, and you can also check out the contact information and try to schedule a meeting with someone. So if you've heard something interesting today that you want to learn more about, you can learn more about it from the presenter themselves. But again, I'll end by saying thank you to our speakers. Thanks for a great discussion and presentations, and I hope you all have a great rest of your evening. Bye, everyone.
Thanks, Catherine.
Thanks.